from the medical team of Zydus. We are very thrilled to attend and be a part of today's discussion. Thank you, MHG, for letting us be a part of today's discussion. So for further discussion, I'll hand over the session to Dr. Amit sir. Sir, over to you.
Thank you, Dr. Shivash. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Aditi Shastri from New York, USA, and she's going to lecture us on MDS, an updated approach to diagnosis and treatment. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Aditi Shastri from Bronx, New York. All our discussants who are themselves very eminent hematologists and medical oncologists, and you participants who are spending your Saturday evening, morning and afternoon. Tomorrow, that is Sunday, 17th of December 2023, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on systemic mastocytosis by our own guest speaker, Surgeon Commander Dr. V.A. Arun from INHS Aswini Kolaba, Mumbai. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. A.R. Jaswinthini from Yashoda Super Specialty Hospitals, Hyderabad. Dr. Akshay Mandloy from Agilus Diagnostics Mumbai Reference Lab, Mumbai. Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun. Dr. Chandrasekhar Bendi from Mahatma Gandhi Cancer Hospital and Research Institute, Vizag. Dr. Deep Gala from SGPJ, Lucknow. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Ketan Modak from National Cancer Institute, Nagpur. Dr. Krishnarathanam Kannan from Sundaram Medical Foundation, Chennai. Dr. Kunal Goyal from Actract, Mumbai. Colonel Dr. Kundan Mishra from Command Hospital, Lucknow. Dr. Lalit Mohan Sharma from Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Dr. Madhura Tinaikar from Bharati Vidyapit Medical College and Hospital, Pune. Dr. Mona Vijayan from SGPJ, Lucknow. Dr. Mohammad Rifai from Government Medical College, Calicut, Kerala. Dr. Mukul Agarwal from AIIMS, New Delhi. Dr. Narendra Kumar Chaudhary from AIIMS, Bhopal. Dr. Navid Tamboli from Mumbai. Dr. Nitin Gupta from Sir Gangaram Hospital, Delhi. Dr. Rajkumar Ramaswamy from Velamal Super Specialty Hospital, Madurai. Dr. Ramesh Balasubramaniam from Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. Dr. Rizwan Akhtar from SGPJ, Lucknow. Dr. Saikat Datta from Bansal Hospital, Bhopal. Dr. Saswat Saha from Tata Memorial Center, Parel, Mumbai. Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida. Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow. Dr. Shyam Agarwal from Sir Gangaram Hospital, Delhi. Now is the time to introduce our guest speaker for the day. We are with us, Dr. Aditi Shastri from New York, USA. Dr. Aditi Shastri is an associate professor in the Department of Oncology at the Department of Developmental and Molecular Biology at Montefiore Instant Cancer Center in Bronx, New York. She obtained her MBBS degree at the Lokmanya Tilak Municipal Medical College in Mumbai, India, and completed her internal medicine residency at the Baylor College of Medicine in Houston, Texas, followed by a fellowship in hematology and oncology at the Montefiore Medical Center and Albert Einstein College of Medicine. She joined the faculty of the Department of Oncology in the year 2015, and in the year 2020, she received a secondary appointment with the Department of Developmental and Molecular Biology. Her clinical expertise is in treating patients with myeloid malignancies such as MDS and AML and adult bone marrow failure syndromes. Her lab focuses on therapeutical targeting STAT3 in MDS and AML stem cells, as well as projects with large clinical and genomic data sets that have a healthy equity focus. She is developing multiple therapeutics for treating therapy-resistant MDS and AML in a lab as well as clinically. Recently, her clinical and research focus has expanded to include pre-disease conditions such as clonal hematopoiesis. She has over 60 peer-reviewed publications, and her research has been funded by NIH, the Leukemia Lymphoma Society, and the MDS Foundation, among others. And today, she is going to lecture us on MDS, an updated approach to diagnosis and treatment. Well, thank you so much. Over to you, Dr. Aditi Shastri.
Thank you, Dr. Khurana, for a very kind introduction. I know that we have a lot of material to cover, so I'm going to just dive straight into the lecture. It's my great pleasure and honor to have an opportunity to speak with hematologists in India, as well as I was informed by Dr. Agarwal that a lot of low middle income country hematologists also really like your webinar and follow and attend. So I hope that some of this content is useful to everyone. So I think this is a perfect time to actually talk about myelodysplastic syndromes updates as we are fresh from ASH 2023, where there were definitely some updated data. These are some of my disclosures that I would like to share. And I wanted to just put out a plug there to say that if you wanted a PDF copy of this presentation, or if there were patient cases that you would like to discuss, please do feel free to email me on this email. And this was a nice red blood cell that I met at ASH last week. So it was a nice meeting and got a lot of good updates in MDS. So just by introduction, myelodysplastic syndromes is a group of malignant hematopoietic disorders characterized by bone marrow failure, cytopenias and resultant complications. Evidence of clonality is a very important hallmark, which we could pick up by cytogenetic abnormalities or somatic gene mutations. And dysplastic morphology, which is noted on the bone marrow aspirate and biopsy, is really the hallmark of the disease. And high-risk MDS has about a 30% tendency to progress to AML. Now, the annual incidence, if you look at claims, some of the data sets like SEER might say that it is low. But if you actually look at claims-based registries, you will see that the incidence of MDS, which is kind of undiagnosed, at least in the United States, can be quite high. And sometimes these patients are just being followed in primary care for many years before they receive a diagnosis. It's typically a disease of the elderly. So as you see, the median age of diagnosis is about 71 years. So this is actually just a schema from a publication that we did a review for in Blood several years ago. And I think this still stands true today, because we see that therapies that we develop in low-risk MDS are so significantly different from therapies that we develop in high-risk MDS. So if you look at low-risk MDS, what is this? This is really a disease which is a differentiation blockade, at a biological level. So when you have the healthy cells progressing from this stage of a long-term hematopoietic stem cell to short-term hematopoietic stem cell to a multipotent progenitor, and then CMP, followed by the megakaryocyte erythroid progenitor and granulocyte monocytic progenitor, you see that in low-risk MDS, the blockage is really a differentiation block at the level of the common myeloid progenitor. And this is why we see that cytopenias are really the most important problem that we face in the disease, and we need to find ways of dealing and overcoming the cytopenia. If you look at high-risk MDS, now this is a disease where there is less of a differentiation blockade, but it is a more proliferative type of disease with a tendency to progress towards a more aggressive type of disease, which is acute myeloid leukemia. So here where we see this sort of accumulation in the granulocyte monocyte progenitor compartment. So in short, I guess what I want to say is, although what we see is really in the bone marrow pathology or karyotype, going back, this is really a disease which is an alteration in the stem and progenitor cells that exist in the bone marrow. And until we have good curative therapies that target these disease initiating stem progenitor cells, it will be actually hard to cure the disease per se. So what are some key updates for MDS in 2023 going into 2024? So we have an updated classification and prognostic systems from the WHO as well as the ICC, which we will go over. We have also the IPSS-M, which is helping us, prognosticate patients better. we have some updates in low-risk MDS, and chiefly these updates are really the COMMANDS trial data, where luspatercept was compared upfront with erythropoietin, an update from the MEDALIST study with luspatercept treatment post erythropoietin or ESAs in the first line, the update from the iMerge, which is where we see the advent of a novel type of therapy for MDS, which is a telomerase inhibitor, imetelstat, and then some updates from high-risk MDS that we thought were noteworthy. So what are some recent developments in our recent care? So since 2020, we have actually had an increase in the pace of innovation and potentially FDA approvals for MDS. And in 2020, we had 2 FDA approvals. One was luspatercept for low-risk MDS, specifically the subtype with ring sideroblast after the failure of ESA. We then had oral HMA, hypomethylating agent therapy, with cedazuridine and decitabine approval. Then we had a new prognostic scoring system, which is the IPSS-M, incorporating molecular or genomic findings, followed by now luspatercept in the first line. And then we have ivosidenib, which is our IDH1 inhibitor that was already approved for treating acute myeloid leukemia, which is now approved for treating myelodysplastic syndromes. So definitely there are lots of things in the pipeline. The most interesting ones seem to be, of course, imetelstat, which is the telomerase inhibitor, and then the BCL2 inhibitor venetoclax, which is being tested in a large phase 3 randomized clinical trial with azacitidine. So one of the largest challenges we have always had in treating patients with MDS has been the impact of transfusion dependency, or just the transfusion burden, which really to a large extent correlates with the survival for our patients. And this has been a long-standing challenge. If you look at this publication from 2007 from Dr. Luca Malcovati to a more updated publication from 2016, transfusion-independent patients always do better than those that are transfusion dependent. So this is really one of the biggest challenges, is to bring your patient up to this level where they are transfusion independent. And this just bodes better for survival, for potential for consideration as an allogenic stem cell transplant recipient, etc. So this has always been a key challenge in our field. Sorry, okay. So I'm going to actually go over a quick case, and if somebody wants to chime in here and give their feedback, that would be good. So this is a case. So we have a 72-year-old woman, Shanti, who was referred to the clinic by primary care or the general practitioner. And what you see here is she's anemic, right? So her hemoglobin is 7 grams per deciliter. Platelets are okay. Absolute neutrophil count is 5,000. There's no evidence of bleeding or nutritional deficiencies. And now, after you have done all the workup to rule out any other causes, you find that on the bone marrow, there is about 17% ringed sideroblasts with erythroid dysplasia. There are 2% bone marrow blasts, and the karyotype is normal. And so here you can see very nicely the ring sideroblasts, which are really iron trapped in the mitochondria, which you can pick up on a Prussian blue stain. So let me ask maybe one of our discussants, please feel free to unmute and tell me a little bit that what would you do next? And I want to hear about potentially incorporating maybe genomic testing and any testing beyond what you have available here.
Yes, so I'm S. Verma here. So we would like to go for the molecular testing routinely. Nowadays we are doing with NGS panel. So we'll like to see whether SF3B1 mutation is there or not. And we would also like to do the EPO erythropoietin levels, because now we have to plan the treatment of the patient.
Yes, thank you very much, Dr. Verma. So that was very good feedback. And so once we do NGS or next generation sequencing, we can pick up a hotspot mutation in this case, as we see classically with SF3B1. Checking erythropoietin is also an excellent idea because now we have to plan for treatment with EPO versus luspatercept, as we will see. So one of the questions that came up in ASH when we discussed a very similar case was, can we do genomic testing for all cases? Now, given that there may be some resource constrained settings, even though NGS is widely applicable now across the world, one of the recommendations was that if you can even test a limited panel of actionable genes, right, this is really valuable for the patient as well as the provider to be able to risk stratify and also offer therapies. So my recommendation would really be that we do the SF3B1 for sure. We check TP53 and we check IDH, so these are definitely some actionable mutations in MDS. And, if you have the ability to go beyond a small panel and check a larger panel of myeloid mutations, this is also potentially prognostic in the future. So some of the most important diagnostic criteria are, as we mentioned, dysplasia is a hallmark of MDS. You always try to look for evidence of clonality or an abnormal karyotype, which also you can see very often in these cases, right? And cytopenias. So we do diagnose MDS with cytopenias. And, this is sometimes overlooked, but you have to make sure that when the patient was referred to you, there is a comprehensive workup to exclude cytopenias due to other cases, right, or other causes. So vitamin B12 deficiency, folate deficiency, this is something we still do see, underlying viral infections, potentially copper deficiency. This you will probably see this in people that have malabsorption. And this is not just limited to nutritional malabsorption, but also people that might have had surgery, gastric surgery for obesity, etc. We have to think about these causes of malabsorption, alcohol intake, certain autoimmune conditions. So if you have a chance, take a look at our recent publication in Blood Advances, which actually looks at SEER Medicare data of the overlap of autoimmune diseases and MDS. And there is actually significant overlap in this particular situation. And then, of course, sometimes people are referred late. There may be congenital syndromes. When you are seeing people with MDS, one of the things to also do is to take a good family history, because there are germline MDS cases that you may pick up. So you may pick up Fanconi's, you may pick up people with DDX41 mutations. And this really has implications for therapy as well as consideration of allogeneic stem cell transplant in the future. So this is the updated classification for the WHO, which is the 5th edition. And what we saw here is there was actually a change of the name. So from myelodysplastic syndromes, they really classified it as a cancer now. So it's myelodysplastic neoplasms. And there is incorporation of genomics now in the classification. So you can see the DEL5Q, SF3B1, TP53 that we spoke about. And then, of course, there is morphologic definition, which was previously also captured, but really looking at the percentage of blasts that you can see in the bone marrow that helps you classify these patients as being slightly lower risk or more higher risk with 10 to 19% bone marrow blasts, etc. MDS with fibrosis will be your MDS-MPN overlap syndrome. If we look at the ICC classification now, we see that there is lot of similarities. So of course, there is the genomic classification, which we see has significant overlap with the WHO. And then this is a key difference, is they have actually classified 10 to 19% bone marrow blasts here as potentially AML. So, I think what this tells me is really that this is a case where we can go ahead and use AML-like therapy, right? So we can use debulking therapies, chemotherapy, etc. So, of course, the exception being some sort of AML-defining mutations. So this is kind of interesting here. And then how do we risk stratify patients in clinic? So IPSS is our time-tested tool, which has also been incorporated in several clinical trials where we use variables such as bone marrow blast, the karyotype, and cytopenias to really classify our patients from low to high risk. And then the updated IPSS-R actually used more cytogenetic categories to really give a risk group from very low to very high. And we can see that actually this does correlate pretty strongly with survival, with very low risk patients surviving for much longer than what we can see with very high risk patients that have a poor survival. Now, for a very long time, I mean, this is actually a publication from a decade ago from Dr. Ellie Pape-Emmanuel. We know that genomics play a very important role in MDS and in the prognosis of the disease. And this was the first publication which actually looked at the different types of pathologic classification of MDS and what genomic mutations they were enriched in. Going forward, this is just a breakdown of what are the important mutations or what is the mutational landscape of MDS. And in some sense, this defines the therapies that we use. And so epigenetic regulation is very important, is dysregulated. So some of your TET2, EZH2, ASXL1, DNMT3A, these are some of your top mutations that you do see in MDS. And this is the reason why hypomethylating agents are so successful, because they hypomethylate those parts of the DNA that are hypermethylated due to mutations in these different genes. And then we, of course, have the splicing factors, right? So when there are mutations in splicing factors, there is missplicing of the DNA and production of abnormal proteins, which is why we see a large number of splicing mutations in MDS, especially in those that have cytopenias and low-risk MDS. And going forward, of course, there are many others which are signaling pathway mutations, mutations that impair differentiation, etc. And this is a publication by Dr. Behar, which actually again looked at the genomics of MDS correlating with overall survival data. And here is, again, we get the inkling that SF3B1 are really the ones that are good risk, whereas the others, depending on how many you have, potentially become adverse prognostic markers. So the somatic gene mutations, we do know, improve the precision of the IPSS-R. And so all these mutations, the more number of them that stack up, give you an adverse prognosis. And SF3B1 by and far has been linked to favorable outcomes. And this is a spliceosome mutation. And it is considered to be an initiating genetic event in developing MDS. It is associated with the ring sideroblast case that we just discussed, ineffective erythropoiesis and an indolent course. And typically platelets and ANC are normal. So if you look at the overall survival for patient with SF3B1, typically those again with single lineage dysplasias, have a better survival compared to multilineage, but overall these patients do better. And then now we actually have another prognostic model, which is the IPSS-M, which incorporates genomics and gives us better prediction of what could be poor and favorable outcomes. And IPSS-M was actually trained on over about 3,000 patients, that the samples were collected in Europe as well as Japan. It does, in addition to SF3B1, it does give you a lot of prognostic data and modeling on not just the mutation, but also whether the specific mutation, in this case, let's say TP53, is it monoallelic, is it biallelic? So a lot of this also plays into the score, which you can kind of put in there, this information if you have, that can refine your prognostication. So this is a unique risk score. And now there are 6 different categories. So I will show you that on a graph. And compared to the IPSS-R, the IPSS-M has improved prognostic discrimination across all endpoints and restratifies 46% of the patients. Now, I think this is actually in the long run going to be very good for our patients, but we have to remember that a lot of clinical trials that are ongoing right now have risk stratified the patients already based on IPSS or IPSS-R. So there are patients who get upstaged significantly with the IPSS-M that might have missed going on these studies. So it's a very easy tool to use. It's available online, and you can input your data from the clinical labs, as well as cytogenetics, as well as your mutations to kind of get you a readout. And here you can see you kind of get a nice readout for this patient we discussed is low risk, right? So goes from very low to very high. So we're able to get a visual representation of that as well, which I find is good to discuss with the patients in clinic, because this data points are helpful to look at. So how do we treat patients with MDS? That's our key question, right? So this is a publication that is always updated in American Journal of Hematology by Dr. Guillermo Garcia Manero. And the most recent update also is very similar. So our patients with low risk MDS, we actually have a few different strategies that we will discuss a little more in detail. That really one of the key ones are really now at this point luspatercept, lenalidomide, and ESAs. And then, I know this talks about age in absolute numbers, but I just want to make a point also to say that age is not an absolute number. You might, of course, get younger patients that have several comorbidities, and may really not be a candidate for intensive chemotherapy, versus you may get a 70-year-old who is a marathon runner or something, and then you might say, hey, I think maybe I could transplant this patient, right? And of course, this would be a multidisciplinary sort of decision taken along with the transplanters and other colleagues at your institution. So let's talk about ESAs. So erythropoietin stimulating agents are time tested and have been around for a long time, and we do use them for treating MDS. So the ESAs that I use the most in my practice are epoetin alpha or darbepoetin alpha, and both of these can improve anemia, they can reduce the transfusion burden, and improve the quality of life. Now, one of the key things is we really have to adjust the regimen, of course, to maintain the hemoglobin and hematocrit that is sufficient to avoid RBC transfusions. And the goal or the ballpark that we target is usually 10 grams per deciliter. This is an option that has been out in the literature, which is that you can actually use ESA in combination with the myeloid growth factors as well, like GCSF or GM-CSF, which may be acceptable options for patients that also have low EPO levels and, patients with ring high percentage or more than 15% ring sideroblasts. How do we know which patients respond to ESA? So this is some nice work from Europe, which actually tells us that they have a kind of prediction tool. So if you want to use this in the practice, you can actually look at it. But if you just see here, the features of the prediction tool are really just the serum EPO level, as well as your transfusion burden. Just eyeballing it, you can tell that high EPO level and high transfusion burden predicts for poor responsiveness or primary ESA resistance, right? So this may be cases where you want to consider other therapies. So patients do relapse of ESA. So there are relapses are common once there is loss of response. If a person does respond to ESA, the median duration of response is usually 18 to 24 months. So this has been one of the latest advents in treating MDS, is really understanding what is driving the differentiation arrest and anemia. And a lot of this work was actually done, this preclinical work was done at my institution by Dr. Amit Verma to kind of understand that excessive SMAD2/3 signaling and upregulated TGF-beta pathway is the one that really causes a maturation block at the level of the terminal erythroid differentiation stage. And these TGF-beta ligands like GDF11, GDF15 are the ones that negatively regulate late erythropoiesis. Now, luspatercept is basically a fusion protein that consists of a modified activin receptor, which is a member of the TGF-beta superfamily, and a FC portion of a human IG1. And this basically downregulates the TGF-beta pathway. It speeds up terminal erythroid differentiation and relieves a critical differentiation block that we see. This is the updated data from the phase 3 command study, where we actually had this updated earlier this year. And in the commands, luspatercept was tested head-to-head with epoetin alpha for upfront management of MDS. So in this study, patients that were over age 18 were enrolled, very low to intermediate risk with less than 5% bone marrow blasts. They had to be RBC transfusion dependent, which was defined as 2 to 6 units for 8 weeks, for a minimum of 8 weeks, immediately prior to the randomization, with an EPO level of less than 500. So this was actually done to give EPO also equal chance to really work, and the ESA naive patients. And so here they were randomized 1:1 to luspatercept 1 milligram per kilogram given subcutaneously every 3 weeks and up titrated to 1.75 milligram per kilogram, and epoetin alpha given 450 units per kilogram subcutaneously and up titrated to 1050 units per kilogram. And what was the response that was monitored? The response assessment was actually done at day 169 and every 24 weeks thereafter. And then there was end of treatment was defined as lack of clinical benefit or disease progression per the IWG criteria. So if you look at the primary endpoint, luspatercept met the primary endpoint. So of the 301 patients that were included in the analysis, 58.5% of patients that received luspatercept and 31% of patients that received epoetin alpha achieved the primary endpoint. And this was a RBC transfusion independence of more than equal to 12 weeks with concurrent mean hemoglobin increase of more than equal to 1.5 grams per deciliter. So this was actually pretty encouraging activity. So if you look across all the intention to treat population, right? So you see that if you break it down by baseline serum erythropoietin level, the baseline need for RBC transfusion burden, the ring sideroblast status, and SF3B1 status across all the categories, except for this one here, which is ring sideroblast negative, you can see that luspatercept actually performed better compared to the ESA or the epoetin alpha. And there is a prolonged duration of RBC transfusion independence that we see with luspatercept versus epoetin alpha. So let's break it down now into the ring sideroblast positive cases versus the ring sideroblast negative cases. So in the positive cases, I think we can say quite confidently that luspatercept did better head-to-head to epoetin alpha. You see a response median duration of 120 weeks compared to 47 weeks. Whereas in the ring sideroblast negative case, this is not very clear. So if you ask me, I think here you can perhaps, go with either agent. I don't think the data is really not really in favor of luspatercept being better. Anecdotally, I will tell you that even among ring sideroblast negative cases, I have started them on luspatercept first line and achieved a response, and also start EPO. So I think for me, this is I would start with either agent if required. So this was just update that was given at ASH this year, which is that the primary endpoint from the commands of achieving our RBC transfusion independence of more than 12 weeks with a concurrent hemoglobin increase was sustained in the patients, and the subgroup analyses showed that the responses were obviously greater for patients with SF3B1 mutants and better for patients with lower serum EPO levels and for patients with ring sideroblast, as we discussed. And the safety summary, let's go over the safety actually, because this is something that can come up in clinic with discussion with your patients. Overall, the drug is actually quite safe. It's well tolerated. Some things to highlight are fatigue. So this is something important that I do talk to my patients about, which is having fatigue when the treatment starts, and hypertension. So in cases where people have pre-existing hypertension, this can be exacerbated when you start treatment with luspatercept. So it is important to inform the patient of this, inform them of monitoring the blood pressure, and if required, maybe up titrate the dose of the antihypertensives if the patient is receiving a response from the treatment. So another thing just to highlight is the drug is very safe. It is not causing any progression of disease. So progression to high risk MDS or AML or deaths were not significantly increased. So some key practical considerations. The recommended dose is 1 milligram per kilogram, but it's important to up titrate if you're not getting a response. So you can actually up titrate to up to 1.75 milligram per kilogram, which is what I do. And the recommendation for hypertension management is something important to discuss with patients while giving this drug. So this is actually just a quick update again on the MEDALIST study. So MEDALIST was actually the phase 3 study evaluating luspatercept for very low or to low intermediate risk MDS in the second line setting. So this was where patients with, the cohort was really enriched for patients with MDS ring sideroblast, no del5Qs, prior ESA treatment, so patients that had become refractory or intolerant, or with higher EPO levels, and that were transfusion dependent, were randomized to placebo versus luspatercept. And disease responses were actually checked at week 24 and then every 6 months thereafter. And subjects were followed for 3 years or more post the final dose for AML progression, subsequent MDS progression and treatment, and overall survival. And this is from the NEJM publication, which again, shows the same thing, that is, if you look at the cohort here, they were of course enriched for the ring SF3B1 subtype and ring sideroblast. All of them were prior ESA failures or likely to be refractory to ESA therapy. And luspatercept performed better compared to the placebo at every time point for achieving the primary endpoint of transfusion independence. So 38% of the patient met the primary endpoint of transfusion independence for 8 weeks or longer, compared to 13% of those in the placebo group. And the median duration of the longest continuous single period of response was 30.6 weeks. So I think the long-term evidence, which was actually recently updated, confirms that there is substantial reduction in the transfusion benefit for patients with the long-term transfusion benefit. Also high burden and overall transfusion benefit was better for luspatercept compared to the placebo. So what about lenalidomide? Let's just talk about this. So we know lenalidomide has also been around and approved for treating MDS for a long time. This is an immunomodulator drug, which is also approved for treatment in multiple myeloma. And the recommendation based on phase 3 evidence is really that it is most active in del5Q MDS, or the deletion 5Q subtype, but it also has some activity in the non-deletion 5Q subtypes. So there have been a few different doses tested across several trials now for lenalidomide in MDS. And the best used dose is really 10 milligrams daily, which is well tolerated without a lot of significant amount of toxicity. Here, we actually can see that, the patients who have del5Q have significant benefit, right, in terms of hematologic improvement, as well as cytogenetic responses. However, even in those that do not have the del5Q, you will have patients that respond. However, the response is obviously not as good as patients that have del5Q. Now, one of the questions that has come up for me in the past is, do you put these patients on anticoagulation? Is there a risk of thrombosis? Like unless they have an MDS MPN overlap, or some kind of proliferative phenotype with a coexisting JAK mutation or something, I don't usually put these patients on anticoagulation because this is a relatively lower dose of lenalidomide, and the patients are mainly cytopenic, so I haven't really seen a very high increase incidence of thrombosis in at least MDS patients that are on lenalidomide. So low dose lenalidomide, of course, is effective in del(5q) patients with anemia. And in this case, very interestingly, without transfusion dependency. So there was a very interesting study where the final update was reported last year at ASH from Spain called the Sintra-Rev study. And this was actually a phase 3 multicenter study looking at patients with del(5q) low risk MDS with anemia, but without transfusion dependency. So this might come up in a situation where you have a patient with anemia, with a diagnosis of MDS, but is concerned about becoming transfusion independent, right? Maybe you may have a very highly functional patient who is a busy doctor or a lawyer and doesn't want to come for transfusions. What can you potentially offer these type of patients? So the one thing that I thought was very interesting in this study is they found that low dose lenalidomide, so a 5 milligram per day continuously, prolonged the time to transfusion dependency from the beginning of treatment. So 66 months to 11.6 months. It improved the hemoglobin levels, and it also actually induced cytogenetic responses, which is interesting. So in some ways, it is causing improvement in the disease and preventing progression of the disease. At this time, I don't routinely recommend putting people on lenalidomide who are not transfusion dependent, but I think this data is interesting and worth following in the future. So let us talk about some new mechanisms in low-risk MDS, and primarily this interesting data from the telomerase inhibitor imetelstat. How am I doing on time, Dr. Khurana?
Please go ahead. It's perfect.
Okay, good.
Time, yeah.
Okay, great. All right. So imetelstat, this has been around for a little bit. It's not a brand new drug, but what is very interesting is that it is a competitive enzyme inhibitor that binds and blocks the active site for the telomerase enzyme. Now, telomerase is selectively upregulated, right, in malignant cells. And in this case, what happens is the whole idea is that the drug selectively targets these malignant cells compared to normal healthy stem cells. So there is a very potent activity in myeloid malignancies. And so the iMerge was a study that was a phase 3 study, including patients with MDS, as well as, again, enriching for those with MDS with ring sideroblast. And this was the phase 3 design of the iMerge, where we saw imetelstat was given to patients with low intermediate risk MDS, those that were relapse refractory to ESAs or high level of EPO, more than 500 milliunits per milliliters, those that had transfusion dependency, non-del(5q), and no prior treatment with lenalidomide or hypomethylating agents. So patients were randomized to imetelstat versus placebo. And now the primary endpoint that we really were looking to achieve was this 8-week RBC transfusion independence. So across the board, we did see that the 8-week transfusion independence going all the way to here 1 year, we found that there was a higher rate of long-term duration of transfusion independence observed with imetelstat versus placebo. And the imetelstat 8-week RBC transfusion independent responders had a longer duration, as we can see, of transfusion independence compared to the placebo, which was quite significant here. So let's talk about the AEs. So this is a different drug. So this is not, I would say the AE profile is definitely something to discuss with the patients, especially the degree of myelosuppression that we see. So grade 3 and 4 thrombocytopenia and neutropenia are the most frequently reported AEs during cycles 1 to 3. Now, how long do the AEs persist? The AEs reverse within a 4-week window. So I think it's important to counsel the patients that when you start, yes, you will see a drop in counts. You might feel that it's counterintuitive. Is the drug actually working for you? But after 4 weeks or so, there is generally a reversal of this pattern of thrombocytopenia, neutropenia. The non-hematologic AEs, on the other hand, are low grade. And their patients, this is a high percentage of patients that have had dose modifications. So you may actually end up starting on a higher dose or maybe lower dose and just titrate up. At this point, the drug is not FDA approved. So there is no real world evidence yet to inform this practice. But as we go along, I think we will have more data on dose modifications, etc., with imetelstat. But there was no drug-induced liver injuries, etc. This is some data that I found really nice and helpful, is that from the publication for the imetelstat in Lancet that was recently published, we saw that there was actually a reduction in the variant allele frequency with imetelstat therapy that actually correlated with the long duration of transfusion independence and increased hemoglobin. So in some ways, if you see here, whether it is SF3B1 or ASXL1, there is decrease in the VAF of these mutations, which tells me that this could be potentially a disease modifying agent. It would be interesting to track over a long period of time what is the progression of patients to high risk MDS and AML that were treated with imetelstat. So what are some take home points for low risk MDS management? So we didn't actually talk about DNMT3 in DNMT inhibitors, but the DNMT enzyme modifiers or the hypomethylating agents can also be used in low risk MDS. And now we also have an oral option, but they are used in a much lower dose and frequency compared to what we use for high risk MDS. There are multiple older publications that detail perhaps 3 days to 5 days of treatment with azacitidine, 45 to 50 milligram per meter squared, which is different from the schedule we use for high risk MDS. ESAs are still here to stay. They improve anemia, quality of life, and transfusion burden. It's very important to optimize the therapy and dosage for them. Luspatercept is now an option for low-risk patients, specifically those with ring sideroblasts, SF3B1 mutations. It is first line and can be offered even before you offer the patient luspatercept, and you can consider it in non-RS population as well. Lenalidomide is still important. It's a very important part of therapy for the del(5q) population. And imetelstat looks really promising and in low-risk MDS, and we will have to see potentially, we will sequence this drug after the failure of luspatercept or EPO in low-risk MDS. So let's move on. We will move on quickly to high-risk MDS, and we will discuss also transplantation briefly. So here, I think when you encounter a patient with high-risk MDS, the first consideration is really always, is the patient transplant eligible, right? Is this a candidate you would take to an allogeneic stem cell transplant? Is this a candidate for cytotoxic or maybe debulking chemotherapy along the same line? So here you would treat this patient a little differently than if they were transplant ineligible. You really want to put this patient as quickly as possible into a CR and try to bridge them to a stem cell transplant. So here your hypomethylating agents are your best friend. They are the cornerstone of therapy: azacitidine, decitabine. You also can have ivosidenib in this setting, which is a IDH1 inhibitor. And is a differentiating agent and can be followed by transplant. And you have now an oral option, an oral decitabine and cedazuridine. Potentially high-dose chemotherapy, because we are saying that 10 to 19% blasts are now MDS/AML. And a clinical trial, if you have a good clinical trial to offer at your institution. Now, in patients that are not transplant candidates, for me, the priority is really putting them on a clinical trial, because we do have some clinical trials that appear promising and in combination with HMAs. And if this is not an option, then bridging with HMA to potentially ivosidenib, and we have also modified the backbone of the HMA. And I want to actually show you this as well, because I think this is very well tolerated in the patients that we have treated so far. So there is no doubt that hypomethylating agents have improved survival in MDS, but I have to say that over the so many decades now, this is disappointing in the sense that we have not made too much progress in high-risk MDS beyond azacitidine. If you look at decitabine as well, although this drug never produced a survival benefit, potentially the point to be made here is if the primary endpoint was assessing the trial slightly earlier than it was, maybe dacogen could have a similar survival benefit as AZA. It's hard to know, but I would say at this point you could use either drugs depending on what is available in your practice. And stem cell transplant. Now, this is the time-tested treatment in high-risk MDS. And if you look at the patients that have been transplanted, they always have done better than patients that are not transplanted, right? So this is again something to always work up. Maybe you never know over time. If you saw a patient, you're not sure. Sometimes I HLA type them because they may improve with therapy and they may become a candidate. And then we have drugs where now we are improving the delivery of the HMAs by making it oral. So what is the advantage of this? I mean, now your patient doesn't have to come in every day of the cycle to get a IV or subcutaneous injection. You can just do it orally. So this is an oral drug that is available for treatment in the United States, Aztec 727. It's an oral decitabine and cytidine deaminase. The cytidine deaminase is to prevent the oral decitabine from being degraded in the gut. And what we can actually see here is really that if you analyze between the two groups, okay, of IV versus oral, there is equal bioavailability. So this is a very good oral option. And what is the latest on this HMA therapy? So the latest is that this is bioequivalent in a large phase 2 study, the oral versus IV subcutaneous hypomethylating agent. And this is an update from the Ascertain study, which was the oral HMA study, which showed that the median overall survival, especially in this subgroup of patients with biallelic TP53 mutations, really did exceed the previously described historical control. So potentially you can prefer this oral HMA in your patients that have high-risk mutations like TP53, etc., based on this data. Now, the expected survival after HMA failure is uniformly quite poor. Unfortunately, after decitabine failure, the median overall survival is between 4 to 6 months. And salvage therapy after azacitidine failure really should you can consider in some cases allo stem cell transplant, though I think this will be challenging. The transplanters will tell you that we would prefer really the patient to be in CR to get a better rate of response from the transplant. And of course, investigational therapies should be considered. So is there a role for venetoclax? Now, venetoclax is a drug which is an oral BCL2 inhibitor, which is approved for treating acute myeloid leukemia unfit for induction in combination with azacitidine. And in the early studies that were done in MDS, we do see that there is actually a very good median overall response rate and a pretty decent median complete remission and hematologic improvement rate in MDS. And the combination of AZA and venetoclax has been associated with clinical responses in patients with high-risk MDS across the whole mutational spectrum. So here we are definitely seeing there is some benefit of using this combination in patients with more high-risk mutations like TP53, ASXL1, the more high-risk splicing factor mutation like U2AF1, etc. So this is actually being tested, and I mean, actually the data collection is complete. We're waiting on the readout of a large phase 3 study of venetoclax and azacitidine in high-risk MDS, which will inform our practice whether we should be adding venetoclax to the hypomethylating agent backbone at this full dose of 400 milligrams Q daily across from day 1 to day 14, so abbreviated schedule, along with our HMA versus the HMA alone, which is azacitidine. Now, what else is exciting in MDS? Now, I want to say, can we potentially actually modify the backbone, this venetoclax-aza backbone, to minimize toxicity? So can we take this big gun agents, okay, minimize toxicity, but yet we are able to maintain the efficacy, that it is actually giving you the efficacy of the DNMT enzyme depletion, as well as the BCL2 inhibitor, which primes the cell for apoptosis without causing a significant amount of cytopenias, neutropenia, sepsis, etc. So this is actually an investigator-initiated study that we are doing at my institution, and I have put a good number of patients on the study. It is led by my colleague, Dr. Mendel Goldfinger. And what we have done is we have modified the backbone significantly. So we are doing almost a metronomic type of therapy, which is where we are giving venetoclax 400 milligrams weekly in combination with a very low dose of decitabine, 0.2 milligram per kilogram, subcutaneously on a weekly basis. And the reason for choosing this dose is really, in preclinical studies, we found that this is really the dose that is causing the DNMT enzyme inhibitor depletion. It is causing the DNMTI depletion without compromising the stem cell, the counts, without causing any debulking per se. So this was some data we reported in ASH on our AML cohort, and MDS is actually ongoing. And here, and the interim data shows that the overall response rate is excellent. It's 71%, 57% of which is 8 patients have achieved a CR. And what is very encouraging is this data here, which is that 5 out of 8 CRs were MRD negative as assessed by multi-channel flow cytometry. And 80% of the patients with TP53 mutation, so 4 out of 5 patients, achieved a CR. I like this regimen. It's very tolerable. You can even give it to patients who are otherwise really unfit, have a high level of comorbidities. It's very well tolerated. So this is something that I have been doing quite a bit in my practice. This is a drug which is interesting and exciting in clinical trials, which we have also pioneered a lot of preclinical science. So IRAK4, which is an important sort of modulator of splicing, is overexpressed in MDS and correlates with a poor prognosis. And the long isoform of this IRAK4 is more expressed in MDS compared to the short isoform. And this is a drug which is currently in trials, which is an IRAK4 inhibitor. And the subset of patients likely to respond are those with splicing factor mutations and potentially FLT3 as well. So what else is exciting? I know we're almost towards the end of our lecture. I just want to mention some important agents in clinical development. Is sabatolimab, which is a TIM3 inhibitor. TIM3 is expressed on the surface of the leukemic stem cells and causes leukemic stem cell renewal as well as for the T cells. And so this is an immunomyeloid agent which has shown some activity in phase 2 studies. Although the primary endpoint was not met, it did induce a long duration of PFS or progression-free survival in those that did respond to the drug. So ongoing phase 3 is there with this agent. There are XPO1 inhibitors which made a big comeback at ASH this year, like selinexor and eltanexor. I have to say that there is some caution to be used with these drugs because they do cause significant mucositis. There is a RARA agonist, tamibarotene, which is currently in phase 3 trials, and also a luspatercept-like drug, which is now in MDS early phase trials, which has encouraging data, the KER050. So with that, I would just like to summarize. MDS is a cause of anemia in the elderly, so this is important to always watch out for. Clinical features and the bone marrow exam help us make the diagnosis. Other common causes of anemia should be ruled out while we work up the patients. Complications are really from progressive cytopenia, infections that occur from cytopenias, and eventually transformation to leukemia. We have prognosis based now on the new model, which is IPSSM. We have updated WHO and ICC classifications that we are now using for further risk categorizing our patients. ESAs, or erythropoietic stimulating agents, are still first line. We also have luspatercept now in first line, especially if there is benefit in patients with the ring sideroblast subtype and SF3B1. Del5Q MDS, the standard of care is still lenalidomide. Imetelstat, or the telomerase inhibitor, is an important drug which has met its primary endpoint in the large randomized phase 3 study. So we have to watch out for this drug in the future. For high-risk MDS, options are still limited. We are still relying on hypomethylating agents, an oral hypomethylating agent, which is equivalent in terms of dose. And there are investigational agents that show promise, in my opinion, are venetoclax and some of these others. Modifying the backbone to give a low dose is something that we can consider in the future. An allogeneic stem cell transplant is a curative option still in high-risk MDS, but the recipient and donor selection has to be done carefully. So I want to thank some people who informed my thoughts and also contributed slides to this talk, which is predominantly Dr. Sanam Loghavi, Dr. Joseph Khoury, Dr. Amit Verma, Dr. D.S. Campello, and Dr. Rory Charles. I really want to give a shout out to my patients who actually teach me more, I feel, than any textbook out there. This is one of my patients who was the oldest stem cell transplant recipient. She had MDS, got AML, and the age of 76, I transplanted her. She's 78 now, and she's really enjoying her life. So patient selection is important. And also thank you very much to the organizers and the audience. And if you have any further questions or things that were not covered here, please feel free to reach out to me. Thank you very much.
Thank you, Dr. Aditi Shastri, for really updating us the entire spectrum of MDS. You really did a fantastic job.
Thank you.
Thank you for being with us today. And now I request all our discussants to please put the raise hand signs so that we can start our question answer sessions with Dr. Aditi Shastri. Dr. Aditi, can you please stop sharing your screen so that we can visualize
Yes.
it? Yeah.
Mm-hmm.
Yes. So anybody want to ask? Yeah. Sir, please go ahead.
Hello.
Yes, sir. Please go ahead.
Thank you, Dr. Aditi Shastri, for an educative session. I have a question, a very practical question on low risk MDS. If you have a patient with low risk MDS and you start them on erythroid stimulating agent, and the patient doesn't respond, how long do you wait? And what is your typical second line? What do you do from there?
That's a very important question, actually, that we face in the clinical practice. So for patients who actually, I do, that there is a lot of data to show that some patients will respond to erythropoietin or erythroid stimulating agents will take a longer duration of time to respond. So I typically wait for at least 16 to 20 weeks minimum to see a response, okay? If you don't see a response, despite a prolonged duration of therapy, I would switch the treatment. If you have an option available for using a drug like luspatercept, this is what I would do. If you don't have availability of luspatercept, I would consider lenalidomide in this setting. If it is del5Q, I mean, for sure that would be first line. But even if it is non-del5Q, I would still consider it. There are patients who do get a response from this kind of therapy. The other situation that I would also recommend is if you think that the patient is not a candidate for either of this, you could consider doing an abbreviated schedule of a hypomethylating agent. So you could just do like a 3 to 5 day. This was pioneered at MD Anderson, just giving low dose hypomethylating agent 45 to 50 milligram per meter squared over 3 to 5 days every month. So I have seen that, sometimes patients respond to this as well if they haven't responded to erythroid stimulating agents.
And is there any role for allogeneic transplant if they are transfusion dependent, heavily transfusion dependent?
Yeah, so in select cases, where the patients are very cytopenic, heavily transfusion dependent, and none of the drugs are really improving their transfusion burden, I do discuss these cases on a selected basis for transplant. I do recommend these patients for transplant on a selected basis. One thing to also keep in mind is if you have a patient with high transfusion burden that you think may go to transplant, there is an important role for iron chelation for maintaining the liver functionality going into transplant. So I would put the patient also immediately on iron chelation while they're getting worked up for transplant.
Just one last question. What is the maximum dose of erythropoietin you can give
So you can give up to 1050.
per kg? Yeah, 1050.
Yep, per kg, yeah.
Once a week.
Yes.
Okay. Thank you very much for the clarification.
Thank you.
Thank you, Dr. Krishnathan Kannan, sir. Dr. S.P. Verma, your question, please.
Thank you, Dr. Aditi. It was a very nice talk. So just wanted to discuss one of our patients. Is 55-year male who was diagnosed as a case of MDS, multilinear dysplasia with low blast and normal cytogenetics, normal fish panel for MDS. In NGS panel, we got ASXL1 mutation. He had basically severe anemia and moderate thrombocytopenia to present with. We started on erythropoietin up to 80,000 units per week for at least 2 months. There was no response. Then we tried lenalidomide also in the lower doses, as you mentioned in your presentation. And currently, in spite of that, he is still transfusion dependent. So we started on azacitidine. He has received 6 cycles of azacitidine as of now, but there is no response. He is still requiring 4 units of Paxel per month with each cycle. So with the failure of azacitidine, what is the other best possibility which can do we can do? He is not transplant candidate, not willing for transplant, ASXL1 mutation.
This is a very tough situation, unfortunately. I have a quick question. Has the blast percentage changed at all? Like, have you seen increasing blasts
No,
or?
no, 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 no,
Okay.
no. It
So
has not gone up. Still, it is MDS with multilinear dysplasia with lower blast. Yeah, low
yeah,
blast.
with low blast. Okay. So that's interesting. I mean, this is a tough situation, unfortunately, given that he's not a transplant candidate, has sort of failed HMAs, right? One of the things I would recommend, if you saw the patients who got venetoclax actually with ASXL1 had a response, to it. So I would consider in this particular case adding venetoclax to the HMA backbone. If you think the patient may not tolerate full dose like venetoclax 1 to day 14, you can abbreviate the schedule like how I showed you. Maybe you can just do it weekly, metronomic dosing, and try it and eventually escalate the dose if you think the patient will tolerate more. But this is potentially the best recommendation, I think, outside of a clinical trial if they are not responding to HMA. Yeah. Mhm.
Yeah. So, is there any experience you have of changing the HMA from azacitidine to decitabine may it help in some of our patients? Is it a possibility?
I actually think that they are quite interchangeable. And I think if you failed one, the chances of responding to another just as a single agent will be quite poor. I don't think that
Yeah.
switching from AZA to decitabine, because if you think about it, it's just a prodrug, right? AZA is just the prodrug of decitabine. So switching is not going to change. I really think adding a drug to the backbone may help you, like maybe just use
Yeah.
venetoclax with a lower dose
Okay.
if there's response. The caveat to that being, though, the patient, once they fail venetoclax, they really have poor survival. Unfortunately, we don't have good drugs in that situation. Yeah.
Yeah, my last question is like you mentioned about luspatercept in low risk MDS. So the major side effect is the severe, lethargy, weakness, asthenia like features are there. So in a context where a patient is already presenting to us with the anemia related weakness, lethargy and all, and with the continuation of this drug, if the side effect profile is like this, so how would you manage or counsel these patients? Do you also use some, anabolic steroids or something like for, treatment of asthenia,
That's a good
weakness?
point. I actually have not used anabolic steroids. I have found that in patients who respond to luspatercept, the fatigue does improve. You know, the patients who don't respond are the ones who continue to have fatigue without response. Because if you think about it, as your hemoglobin goes up, it will compensate for the effects of the drug. But generally, I don't really use anabolic steroids or anything. Yeah,
Thank you. Thank you.
sure.
Dr. S.P. Verma. Dr. Lalit Mohan Sharma, your question, please.
Yeah, thank you. Thank you so much, Dr. Aditi. It has been excellent talk after a long time on MDS, and you covered a lot of things in 1 hour. The question is about dose of venetoclax. How much you start and how much is the maximum dose you are able to deliver?
That's a good point. So, as I told you, when we start at this point, we still are waiting on data, right, from the phase 3 study for venetoclax. So, what I actually do, and I can share this slides with you, we actually are doing just a metronomic dosing of venetoclax. We are doing 400 milligrams weekly with decitabine 0.2 milligram per kilogram. But as per the design of the Verona study, which is they are actually doing a venetoclax ramp up. So like day 1 to 3, 100 to 400 milligrams and given over days 1 to 14. I will say though, if you are using concurrent azole, for antifungal, you have to significantly drop this drop down the dose. So about 70 milligrams is probably the best dose of venetoclax to use if you're using concurrent azole, strong azole drug for antifungal prophylaxis.
Thank you. Thank you so much. Thank you.
Thank you.
Thank you, sir. Dr. Ramesh, your question, please.
It was an excellent presentation, ma'am. I have a couple of questions. My first question is, for a patient of low risk MDS, like having a very few blasts in the bone marrow, but having one high risk mutation, should we, if the patient is transplant eligible, can we straight away take up the patient for transplant, or should we treat the patient like a low risk MDS? Like, should we try EPOs or LEN and then plan for a transplant if patient's not doing well?
Okay. Yeah, I mean, what do you mean by patient is not doing well? Like they are not tall, they are cytopenic, or what is the situation?
They're cytopenic and requiring transfusion. Since you take up the patient for transplant at that point of time, or the patient has got one high risk mutation, but the blast percentage, the tumor burden is per se less. And can we take up the patient for transplant straight away?
Yeah. So usually I try to give them some treatment with ESAs or luspatercept or something, if the blast percentage is not high. If it's not high risk MDS, I don't typically take them to transplant, even if they may have a poor mutation like ASXL1, etc. So I do prefer to go through the algorithm of using, because I have seen some patients recently I had a patient with a similar picture, ASXL1 mutation, having a benefit from luspatercept. So if you are able to control their disease with the agent that can be delivered easily once every 3 weeks, I think that would be good. If you see a change in the pattern, like you see that they are having increasing blasts, they're becoming more you lost the transfusion response, and you did at that point, then I would definitely recommend a workup for consideration of, because these patients will progress, we know that, right? Like those that have ASXL1, etc. Transplant in TP53 is very, what can I say, at this point, at least in the US, very controversial. You'll see some centers will still offer it because it's still the only curative treatment. But if you look at the outcomes post-transplant, it's extremely poor, like 10% or so patients survive, post-transplant. So I think if they have this biallelic type of TP53 or one hit with TP53 loss of heterozygosity, those patients, I'm not sure. I actually try not to transplant them unless, they are very robust or there's evidence that, oh, maybe they might, but it's hard to know if they will respond to transplant at this point. Yeah.
Okay, ma'am. The second question is, what's your treatment approach in therapy-related MDS? treatment
Yeah,
related.
yeah, so therapy-related MDS, we didn't talk about it too much, but typically therapy-related MDS has some of these worse mutations as well, right? ASXL1, PPM1D, etc. These patients typically progress faster, right? So these are the patients that I do prioritize them for more high-risk MDS like therapy, HMAs, and workup for allo transplant.
Okay, thank you.
Thank you.
Thank you, Dr. Ramesh. Dr. Jaswantini, your question, please.
Hello, ma'am. Thank you for such a nice lecture. I have quite a couple of questions. The first is 66-year-old female, MDS with 5q deletion. We have put her on lenalidomide and she was transfusion independent for 3 years. And now she started developing cytopenias and she lost her response to len. HB is always around 8. Sometimes it falls to 7. So she started having the transfusion dependency at least one every month. So we repeated all the marrow, keratopic, and the panel. No change. Only she has only 5q deletion. So we started her on AZA and azacitidine for 2 cycles. She responded well. Her HB is improved. Should we continue AZA or can we consider taking her for transplant since she has failed len? What is the role in such cases, ma'am? Len failure.
Yeah, it's a good point. I mean, she's Len failed, but she's still Del 5Q, right?
Yeah, ma'am.
She doesn't
Yeah.
have any adverse prognosis
No.
and things like that. Yeah. So I would use as a bridge. So if you can just use azacitidine till you start seeing some loss of response and then bridge to transplant, that's basically what I would do. Because switching out with dacogen at that point will not help. So you can use AZA as a bridge, I would say, to if you start seeing because median duration of response to AZA would be 9 to 10 months or so, right?
Yeah.
So you can definitely use as a bridge if you're concerned that the patient is eventually going to lose response to AZA or use, at this point she's transfusion independent, so you have some time to,
some time to
some time to do the workup,
yeah.
find a donor, etc. Yeah.
And one
Yeah.
more is how frequently you follow patients ITIS and IDIS, ma'am? Can you throw some points?
Yeah, that's a good point. So I'm starting to get more referrals from primary care and other places with clonal cytopenias of undetermined significance, or clonal hematopoiesis. And these patients, we are actually following them in clinic. We are checking the NGS every 6 months to a year or so, depending on how the burden of disease or specifically in terms of mutations. I follow the patients with therapy-related CHIP or CCUS more frequently, like every 3-4 months to check counts. And we will still check NGS also every 6 months because these patients have a higher likelihood of progressing to MDS. The
Can we
CCUS,
do this from peripheral blood, ma'am, than from a marrow, repeating a marrow every 6 months?
I only check peripheral blood. I don't do marrow for these patients. Yeah. Because, the problem is we don't know the epidemiology of CCUS yet very well. We don't know how many of these patients will actually progress, right? The one that I'm also a little careful about, and I may consider cardiology referral for them, is those that have JAK2 mutant chip. There are patients with JAK2 mutant clonal cytopenias or JAK2 chip that have increased risk of thrombosis and cardiovascular disease. So those you can consider to refer to cardiology as well, just to work up. Yeah.
Thank you so much.
Thank you.
Yeah.
Thank you, Dr. Jaswantini. Dr. Saikadatta, your question, please.
Thank you for excellent talk, Dr. Aditi. Am I audible?
Yes.
Yes. Wow, yeah.
My question would be how confident should I be when diagnosis a patient MDS who are having significant dysplasia, but cytogenetics is normal, full NGS panel is negative, FISH is negative, no other cause for cytopenia, only based on morphological basis of marrow and without increase in blast.
Okay, but you have evidence of dysplasia on your
Yes,
marrow.
that we
The
have.
pathologist says it's dysplastic and cytopenic. Yeah, these are difficult cases. Now, in this case, you have no evidence of normality and no karyotype. It's possible that the NGS panel is limited, like it's not picking up maybe the specific mutations. I would, in these cases also, if it's a younger patient, take little better history for germline because some of the commercial NGS panels don't cover the germline mutations. You can potentially send off a separate panel to check germline like DDX41, Fanconi's anemia genes, etc., just to get a better sense of like what is the diagnosis you're dealing with. In the absence of that as well, if you're convinced that there's no other cause, then I would just treat the patient like they have MDS, check the EPO level, if they are eligible for ESAs, maybe you can start there. Yeah.
Okay, thank you, ma'am. My second question would be like, how is your sequencing of drugs in low risk MDS where SF3B is negative or there is no ring sideroblast?
Yeah, it's a very good question. So I think these are the patients where it's a little more challenging. If they have del5Q, I would just put them on lenalidomide. In the absence of RS also, to be honest, I would just start either ESA or lenalidomide. I'm sorry, ESA or luspatercept to see if there is response. I give them a little extended duration to respond. And if there is no response, then we bridge to hypomethylating agents. Yeah.
And that is in standard dose, or in case of low risk, you use low dose of hypomethylating agent?
I would go with low dose. I would go with 45 or 50 mg per meter squared at a lower duration, like 3 to 5 days or so.
And my third question would be, in CCUS patient who are transfusion dependent, what do you do for those patients?
For CCUS patients that are transfusion dependent, so the question really is, right, do these patients have really MDS, right? Because I feel like dysplasia is such a subjective term, right? Like somebody may think it is dysplastic, somebody may think it's not dysplastic. But for transfusion dependent CCUS patient, I would treat them like low risk MDS.
Okay, thank you,
Yeah.
ma'am. Thank you very much.
Thank you.
Thank you, Dr. Saikar Datta. Dr. Avriti Baveja, your question, please.
Thank you so much, Dr. Aditi, for a wonderful talk. Actually, this question is related to one of my patient. He's having MDS, MLD with complex cytogenetics, and he has predominantly got autoimmune manifestations.
Mhm.
So he was started on prednisolone, and after starting prednisolone, he had a slight improvement in the hemoglobin and the platelet count. So in such cases, what should be an approach in the management of MDS?
Okay, so the patient has complex cytogenetics and has mutations as well and concurrent autoimmune disease. Did I get that
Yeah.
right? Okay.
Yeah.
Yeah. I mean, this is complex cyto and high blast or low blast? Sorry, I missed that.
The blast percentage is 3%. Very
Okay.
low blast.
Yeah. So actually, one of the things that we saw in our publication is that patients with concurrent autoimmune disease and those with karyotypic abnormalities had more risk of progression, So what I would more risk of AML progression. So this is the kind of patient I would actually prioritize for workup for allo stem cell transplant. You can actually consider bridging with HMA. One option is if with full dose HMAs, right, or with venetoclax and hypomethylating agent. One consideration also, this is something I always discuss with the rheumatologist, if it helps, because you can consider maybe also trying immunosuppressive therapy that may help the rheumatologic condition as well as the MDS, potentially like a combination of cyclosporin and Promacta with or without ATG. This is something that in select cases that you can consider to do if the bone marrow is giving you any sign of like being hypoplastic, or if there are any such features, that is an indication for using it, right? Hypoplastic MDS. So in patients that have autoimmune conditions, you can consider this sort of approach as well.
Thank you.
Thank you.
Thank you, Dr. Avriti Baveja. Dr. Madhura, your question, please. Dr.
Yeah,
Madhura.
thank you, ma'am. It was a wonderful lecture. Yeah, so my question is little practical one. in elderly patients with low risk MDS or even MDS with excess blast within less than 10%, have you ever used myeloid growth factors to tide over any infective crisis? Because there is always a concern that it might just increase the blast percentage also. But some patients are really leukopenic and they have some or the other underlying infective episode going on. So I wanted your opinions on the same.
Yeah. So I would say that patients who are low risk and cytopenic, you may consider them in combination with ESAs. There is some data to show that, but in high risk patients, especially the EB1 or EB2 type, I really don't use it because there is this concern for progression of disease to AML. One of the things, I know this is a little bit off-label recommendation, if the concern is really thrombocytopenia and things like that, you could use a thrombopoietic mimetic agent like L-thrombopag, And in L-thrombopag, there is data to show that it causes tri-lineage hematopoiesis, not just platelet response. And this drug, in many studies done in Europe and even in US, has been shown to be quite safe despite the concerns of AML and things. It does actually improve the counts a little bit and doesn't cause progression of disease, at least in my experience. So that's something you can consider, but I generally don't use GCSF that much for MDS patients.
Thank you.
Thank you.
We have some questions from the audience.
Okay.
Dr. Raj Kumar Ramaswamy wants to know about the role of immunotherapy in MDS.
Yeah, that's a good point. I think the role of immunotherapy is still evolving in MDS. We many years ago had studies on immune checkpoint inhibitors in combination with HMA, which turned out ultimately not to be very efficacious or successful. The problem with immune therapy is that myeloid cells are immunologically more quiescent. They don't really express PD-1, PD-L1 markers or immune checkpoints very highly. One of the approaches in clinic is a TIM3 immunomyeloid inhibitor, which is sabatolimab. But we will have to see from the phase 3 study. The phase 2 failed to meet the primary endpoint. So to be honest with you, at this point, I'm not feeling very optimistic about immunotherapy in myeloid diseases. But as newer agents get developed, we'll have to see how they work in the clinical setting.
Thank you. So there are no more questions from the audience. Any discussions wants to ask? Yes, Dr. Jaswanthini, you have another question? Dr. Jaswanthini, Dr. Madhura, yes.
Yeah, ma'am, and one more doubt. In hypoplastic MDS, it is actually difficult to distinguish between aplastic anemia and hypoplastic MDS. So in such a case, is there a role of immunosuppressive therapy as we treat aplastic anemia? Like cyclosporin, L-thrombopag, and ATG?
Yes, so I have used it in cases of hypoplastic MDS. You can actually confirm some things like HLA, DR15, etc.
Yeah.
If you have expression, I have to say you have to really be careful. Like if you have a real concern, like, okay, you have ruled out aplastic anemia, there is clonality, right? Like
Yeah.
you're seeing in MDS, and you have this thing for that it is hypoplastic MDS. Yes, of course, you can go ahead and use ATG, cyclosporin, Promacta. These patients do get a pretty good response from it. In patients you think that won't tolerate ATG, there is actually synergy with just cyclosporin, Promacta alone, which can be done outpatient. Yeah.
Can we take them for transplant, no? Hypoplastic MDS, any role?
Yes, you can. You can. If you're seeing loss of response or you're not seeing response to therapy, overall fit patient, it sort of falls in the same line as aplastic anemia in an adult then, right? And you can consider curative strategies. Yeah. Mm-hmm.
Thank you so much.
Yeah.
Thank you. So any other discussions wants to ask any other question? Well, so there are no more raising signs and there are no questions from the audience. So Dr. Aditi Shastri, that was fabulous lecture, fantastic lecture. You were awesome. And what a wonderful discussion. Thank you for being with us today, evening for us and early morning for you.
Yeah, thank you so much for having me. I really enjoyed the discussion very much, and best of luck to everyone. If you have any questions about your patients or anything, feel free to reach out to me. Thank you so much. Yeah.
Thank you. And I now
Okay.
hand over to Zydus for the final vote of thanks.
Thank you, Dr. Amit. Thank you, Dr. Aditi, for an excellent session today. It was a great learning session for us as well. We are happy and glad to be a part of today's discussion. Thank you. Thank you from Zydus. Thank you, sir.
Yeah.
Thank you, Amit, sir.
Thank you very much. Bye-bye.
Thanks a lot. Bye.
Bye.